inviting me for this great annual scientific event. الحقيقة أنا مش محتاجة invitation إن أنا أجي أي حاجة related لعين شمس عشان هم عارفين كويس قوي إن دي my second home يعني، فأنا هم مش محتاجين خالص إن هم يقولوا لي إن أنا أجي يعني. ومع ذلك إيه؟ لا معلش باجي، لا معلش بقى. And now we come to the second presenter, Dr. Abeer Gdr, and she will present imaging of pulmonary infection in immunocompromised children. اتفضلي دكتور عبير. ودي حاجة كنت لسه عايزة أقول كده، إن السيشن الحقيقة كلها مترابطة وكلها the same subject, the same يعني كلها uniform كده in one category. وإحنا إيه؟ ما هو ده برضو ان انا عايزه اقول كل مره لازم الاقي فيه حاجه كرييتيف كده مختلفه عن المره اللي قبلها. bless you يا شيماء.
بيشكر حضرتك على المؤتمر. السلام عليكم. I'm Dr. Abeer Gdr, lecturer of radio diagnosis. My lecture today will be about pneumonia in immunocompromised pediatric patients. Pulmonary infection is the leading cause of infectious morbidity and mortality in children with immune defects. Lung infections in immunocompromised children. Immunocompromised pediatric patients are more susceptible to common infective pathogens. In general, this will manifest similar features to when seen in immunocompetent children, but may be more severe. Sorry. Bacterial infections. Non-microbial bacterial organisms. احنا عندنا most bacterial infections cause lobar consolidations. The Staphylococcus with Klebsiella infection typically cause consolidation combined with edema, this resulting in bulging fissures. Staphylococcal infection usually associated with cavitations, pleural effusion, nematoceles, pneumothorax. This is a CT chest of a 15-year-old girl with immunosuppressive therapy for aplastic anemia with a history of cough, fever, tachypnea, and chest pain for a week. It shows multiple lung nodules, multiple nematoceles, and left-sided pneumothorax. This is a characteristic of staphylococcal infection, and the suspected organism was grown in sputum culture. Klebsiella infection has a tendency to occur in the upper lobes and form cavities. Pseudomonas infection shows mixed features of multilobar consolidations, air bronchogram, and multiple areas of ground glass opacities. H. influenza infection manifests as a subsegmental or segmental consolidation with peripherally located ground glass opacities, centrilobular nodules, and bronchial wall thickening. Mycobacterial infection. It appears as a cavitating consolidations in the lower lobes, even with 3 impud nodules. Mediastinal lymphadenopathy and pleural effusion is common. Severely immunocompromised patients present with miliary and disseminated pattern of the disease. This is a CT of 12-year-old male, non-case of systemic lupus erythematosus on prolonged steroid therapy, who complains of fever, cough, and chest pain for 1 week. There is a 3 impud opacities along with segmental consolidation in the left lingular segment. The imaging appearance characteristic of tuberculosis, and the sputum smear confirmed tuberculosis. So mycobacterial infection, either tuberculous or non-tuberculous, should be considered in the differential diagnosis of atypical pulmonary infection in the immunodeficient children, particularly if associated with the lymphadenopathy and extrapulmonary diseases. Invasive fungal infections. are amongst the commonest, the most feared, and hardest to treat infections in immunocompromised children. Invasive fungal infections may complicate a broad range of immune defects, but in general, any child with prolonged, more than 10 days of neutropenia is considered at high risk. Children with chronic granulomatous disease are also at risk of invasive fungal infection even without neutropenia. Invasive fungal infections, the three commonest fungal infections are invasive pulmonary aspergillosis, disseminated candidiasis, and pulmonary mucormycosis. Invasive pulmonary aspergillosis presents with a well-defined imaging features consisting of a nodular area of consolidation with a peri-regional ground glass halo. Peripheral regions are typically wedge-shaped. Later in the course of the disease, nodules may cavitate and form air crescent sign. An 11-year-old female patient in El-Demirdash Hospital with acute lymphoblastic leukemia, CT shows multiple focal pulmonary nodules, predominantly seen in the upper and middle lobes. Some are surrounded with ground glass halo, and others shows internal cavities. Disseminated candidiasis. It results from hematogenous dissemination, typically related to skin or gastrointestinal tract infection. It appears as a multifocal disease with multiple small, sometimes miliary nodules in the lung. Other signs of disseminated disease may be also seen in the CT. This is a 3-year-old boy with 4 weeks of febrile neutropenia following treatment of pre-B cell acute lymphoblastic leukemia. Contrast-enhanced chest CT shows multiple small pulmonary nodules, some showing ring enhancement. CT of the upper abdomen demonstrate multiple small ring-enhancing lesions and extensive lesions in the spleen. Biopsy from the spleen confirmed candidiasis. Mucormycosis is a rare, aggressive form of invasive pulmonary infection. Imaging findings typically resemble those with invasive pulmonary aspergillosis, but is multifocal disease associated with sinus disease. A pleural effusion is seen in mucormycosis more than invasive pulmonary aspergillosis. Poor response to treatment may lead to large lesions. This is a 12-year-old girl with hemoptysis and suspected fungal infection following treatment of acute lymphoblastic leukemia. There is a large lesion in the left upper lobe with a small pleural effusion is present. Some multiple nodules are seen elsewhere. Following poor response to treatment, a left lobectomy was performed and confirmed mucormycosis. Other fungal infections. Pneumocystis jirovecii pneumonia occurs almost exclusively in patients with depressed cell-mediated immunity, especially those with lymphopenia. So, who is susceptible? Children with severe combined immune deficiencies, intense treatment for hematological malignancy, hematopoietic stem cell transplantation, prolonged steroid treatment, solid organ transplantation, and advanced HIV treatment. Effective chemotherapy for Pneumocystis jirovecii pneumonia has substantially reduced its incidence from 25% to less than 1%. However, once infection is established, mortality remains very high. Typical CT findings include bilateral ground glass attenuation with upper lobe predominance and peripheral sparing, often with mosaic distribution and sometimes with septal thickening. Rarely, there is interstitial gas leak may occur, producing cysts, which may be resist, pneumomediastinum, and pneumothorax. This is a 2-year-old boy in El-Demirdash Hospital with febrile neutropenia, lymphopenia, shows extensive patchy and confluent areas of consolidation surrounded with ground glass opacities, reticular interstitial thickening in both lungs with relative sparing of the periphery, a few small cysts in the left upper lobe with interstitial gas leak and pneumomediastinum. Viral infection includes cytomegalovirus and coronaviral disease. Cytomegalovirus, CT is frequently performed and will demonstrate ground glass opacities with or without consolidation. Mosaic attenuation pattern, nodular or articular opacities may be also seen. There is an overlap in the CT findings between cytomegalovirus and Pneumocystis jirovecii pneumonia. This is a 7-month-old boy with severe combined immune deficiency and active cytomegalovirus viremia. There is a patchy ground glass opacity throughout both lungs. Diagnosis of cytomegalovirus pneumonia requires demonstration of cytomegaloviral material in the blood or respiratory secretions. PCR is the modern diagnostic technique of choice, with bronchoalveolar lavage more sensitive than serum samples. And this is a summary for opportunistic infections and their typical imaging findings in immunocompromised children. Awareness of differential diagnosis in different clinical scenarios help the radiologist and multidisciplinary team to narrow the differential diagnosis and give the patient the best antimicrobial therapy. So, the algorithmic approach toward this pulmonary infection in immunocompromised patients depending on the pattern of the disease and the clinical scenario. When I see a lobar consolidation, this indicates a bacterial infection, either with Staphylococcal, Klebsiella, or Pseudomonas. As aforementioned, the presence of bilateral empyema, pneumatoceles, pneumothorax is in favor of this staphylococcal infection. But all these organisms can cause deterioration to necrotizing pneumonia and vasculopathy. If I see diffuse ground glass opacity, it's likely diagnosis is Pneumocystis jirovecii pneumonia, cytomegalovirus, or COVID-19. If there is acute onset of the disease with rapid deterioration to respiratory failure in a solid organ transplant patient or hematological malignancy or ICU patient with some features of ground glass opacity cystis pneumomediastinum, I will suspect Pneumocystis jirovecii pneumonia. Cytomegalovirus is suspected when in HIV patients, low CD4 counts, transplant recipient patients with very high ground glass opacities and septal thickening and crazy paving, I will suspect cytomegaloviral infection. If there is bilateral peripheral ground glass opacities, I will suspect COVID-19 infection. If there is a halo sign in a clinical setting of acute onset febrile neutropenia, fungal infection of angioinvasive kind occurs in patients with hematological malignancies, solid organ transplantation, and febrile neutropenia. But the differential diagnosis includes herpes simplex pneumonia, microbacterial infection, and granulomatosis with polyangiitis. If we see miliary lesions, this indicates a Mycobacterium tuberculosis infection. The differential diagnosis including viral infection with herpes family and fungal infections such as histoplasmosis and candidiasis as aforementioned. Mixed findings, consolidation, ground glass opacities, bronchial wall thickening, and tree and bud opacities, and fibrosis, this all occur together in Mycobacterium tuberculosis infection. The coexistence of lymphadenopathy and pleural effusion help in diagnosis. Although the final diagnosis is confirmed by isolating the offending organism from blood, sputum, or respiratory tract secretions, CT remains the clinical imaging investigation in most cases of suspected pulmonary infection in immunocompromised children. So, immunocompromised children with respiratory signs or symptoms or prolonged fever more than 48 hours should usually undergo CT examination without unnecessary delay. The addition of intravenous contrast in help in many cases. It allows identification of lymphadenopathy, assessment of pulmonary vein patency, detection of necrotizing changes within nodules or areas of consolidations, delineating pleural collection adjacent to areas of consolidation. Follow-up CT scan done after a minimum of 2 weeks to assess treatment response. Invasive fungal infection may appear worse during response to treatment in the first 2 weeks, so early follow-up may be misleading. Summary: pulmonary infections are the leading cause of morbidity and mortality in immunocompromised children. Imaging plays a central role in establishing diagnosis and narrow down the differential diagnosis. Thus, imaging needs to be interpreted carefully in a full patient context in a multidisciplinary setting in order to guide empirical treatment and direct further invasive testing as required. Thank you.
Any question for Dr. Abeer?
النقطة بتاعت إن إحنا نعمل سي تي just طبعا أنت عارف الراديشن خلاص. فإحنا هل from the very beginning to ask for CT just with contrast من الأول؟
هو طبعا دكتور خالد يعني هو اللي علمنا انه الروتين اصلا بتاع السي تي شيست السي تي شيست بس كونتراست. طول ما احنا عندنا كونتراست لازم نعمل سي تي شيست بس كونتراست. ممكن في الفولو اب لو كان في شورتج في الكونتراست
كالعاده
بس في الفولو اب نبقى احنا عرفت الليجنز الاساسي فين ومكانه فين، وعرفنا في ليمفادينوباثي ولا ما فيش، في بلورال افيوجن ولا ما فيش، لان الحاجات ديت اللي بتوضحها في نيكروزز جوه النيمونيا ولا ما فيش، كل ده بيوضحها الكونتراست.
طب what do you think about the high resolution CT؟ يعني احنا مثلا عندنا روتين في عيانين الاميون ديفيشنسي لايك الكومن فاريبل اميون ديفيشنسي والاجاما انه لازم يتعمل لهم بيز لاين هاي ريزوليوشن سي تي ده بير جايد لاينز، وبعد كده بنعمل فولو اب بعد سنه ل6 شهور according and we advise طبعا ان يتعمل MRI تشست عشان الريبيتد اكسبوجر لان العيانين لازم يعملوا كل سنه. طب الهاي ريزوليوشن سي تي will not go يعني I will not serve like السي تي with contrast.
هو يعني هي هاي ريزوليوشن سي تي ده يعني ترم قديم شويه، احنا كل السي تي بتاعنا بقى هاي ريزوليوشن دلوقتي. فاحنا محتاجين كونتراست زي ما قلت لحضرتك في الاول، عشان مثلا لو هو العيان ده عنده تي بي انا هعرف منين اذا كان عنده ليمفادينوباثي ولا لا من غير كونتراست. فاحنا على الاقل ده انيشالي سكان نعمله بكونتراست، بعد كده لو قريب مش لازم نعمله كونتراست.
يبقى معنى الكلام عشان احنا بس ننقل الانفورميشن ان انا I don't need to write in the request high resolution CT لانها باي ديفولت بقت كله هاي ريزوليوشن CT. ثانك يو.
انا ليا تعليق بس تاني للدكتوره داليا طالما انت اللي هتنقل المسج بس. الستاندرد سي تي باي ديفولت هو ويز كونتراست، مفيش سي تي ويزاوت كونتراست. احنا وقعنا في المشكله دي بسبب حاجتين، بسبب الايرا بتاعت الكوفيد احنا كنا بنصور كميات ضخمه جدا وصلت ل 200 و 300 حاله في اليوم، فما كناش بنصور بكونتراست. تمام. الحاجه الثانيه الديفيشنسي بقى اللي ابتدى يحصل دلوقتي للظروف الاقتصاديه، لكن هو باي فار الستاندرد سي تي ويز كونتراست على الاقل الانيشال ستادي. لكن لو انا عارف انا هعمل ايه بعد كده انا او داخل اعمل فولو اب لايه او بدور على ايه ممكن استغنى عن الكونتراست، بس ده برضو هيبقى جايدد بان احنا عارفين العيان ده قصته ايه وحكايته ايه وشايفين الفحص بتاعه ايه. بس باي فار السي تي تشست از ويز كونتراست، ده الستاندرد ستادي. وزي ما عبير كان في سؤال تاني انا نسيته هقول لك عليه بعد ما خلاص. شكرا يا عبير، شكرا جزيلا.